Good afternoon and welcome everyone to the third and final session of the RMBA AI webinar series titled Frontiers in Radiology, Navigating AI's Role. Today we'll be discussing scaling AI in radiology business. Please feel free to participate by asking questions or sharing your thoughts in the chat throughout our time together from 3 to 4 p.m. Eastern Time. We'll periodically stop our presentation to answer these questions. This session is currently being recorded and will be available 24 hours after the session concludes. Greg, would you mind going to the next slide for me? Thank you. Now let's extend a warm welcome to our speakers today. Greg Zaharchuk, MD, PhD, is a professor of radiology and practicing neuroradiologist at Stanford University and a founder of Settle Medical. His undergraduate training was at Stanford University, followed by a PhD from Harvard, MIT, and MD from Harvard Medical School. Catherine Keller, MD, is a seasoned diagnostic radiologist and former president of Six Lake Medical Imaging Centers. She earned her MD from the University of Chicago's Pritzker School of Medicine, completed a diagnostic radiology residency at Henry Ford Hospital, where she served as chief president, and pursued a neuroradiology fellowship at the University of Miami. Dr. Keller has been a leading advocate for breast health and has significantly contributed to advancing imaging technologies in Florida. We're thrilled to have you both on today. Thanks for joining us.
Okay, would you like us to start?
Yes.
Okay, sorry.
No worries.
So thank you for joining today. I'm going to be talking a little bit about radiology and AI and how I think that we need to think about them in terms of implementing them into current clinical practice. I want to start with a brief history of radiology revolutions because I think we're in the middle of one now. Of course, in 1895, we had William Röntgen, who was the discoverer of the X-ray and who our field is named after. It took quite a few years before we had any other modalities, and this was 1927 when Edgar Moniz discovered angiography by injecting contrast into people and imaging the blood vessels. And it took another long period of time before we had a new modality, which was CT in 1970s, followed by MRI, really in the 1980s, although it was invented a little earlier. And I think the next really big revolution in our field was the invention of PACS. PACS has, really been a huge driver of our field forward technologically. And what I would say now is we're really in the stage where AI is now starting to enter that space. Okay, so you might be asking, how is AI going to help the field of radiology? And one of the things that I always get asked is it going to read scans for us? And this is very popular in the media. This is a quote that some of you may have seen by a very famous AI researcher. And what he is saying is that AI is so good that we should just stop training radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. And I also include the date of his speech here. And you can see that we've passed that quite a few years ago. And there doesn't seem to be any sign that AI is going to take a lot of work off of our plate in terms of the diagnostic aspects. And there are a couple of reasons for that, one of which is regulations beyond performance. So where will it tend to help us? I think that the first places you're going to see it used is to fix existing pain points that we have within our field. And many of you, I'm sure, are aware of these. One of the things that we see at Stanford is just an overload in terms of the demand for imaging and being able to, get this to patients when they need it in a timely fashion. And a lot of what Settle Medical does is to try to solve this problem. I think other things that we need to think about going forward where AIs can be really helpful is to remove unnecessary variability from many processes. There's just saying that variability is the enemy of quality. And I think that's quite true. And I think this is a place where AI can have a big impact, and I'll show you a little bit of that. I think workflows are becoming more and more complex. We're reading from more and more sites. Hospital systems are getting acquired. People are reading remotely. And we need to really simplify complex workflows that we demand for both the technologists and the radiologists. And then finally, one of the great holy grails of the field is to try to improve radiology efficiency and optimize image presentation, which has largely failed, I would argue, over the last 20 years since PACS started, and I'll talk about that as well. Now, whenever we think about these things, we can't think about them in a vacuum and just think about technical ability. We really have to realize these have to fit into our existing infrastructure, which is often IT limited, and the financial constraints will really speed, addressing financial constraints is really going to speed adoption. If you have AI that actually promises a return on investment to hospitals and imaging centers, I think it's much more likely to be adopted. Okay, let's start with increased demand of imaging. Imaging is obviously very useful, but it is costly, and I would argue it is quite inefficient. We are seeing, 5 to 10% growth in all exams. This is 10% growth in MR exams in 2021. We see aging technology and difficulty in replacing technology, I would argue. And then finally, as wonderful as some of these technologies are, patients have difficulty when they meet that part of the healthcare system. Often they're very sick, they're anxious, they're in pain. Dealing with patient discomfort is very important. Okay, so just to kind of frame things, this is a nice paper that's already kind of old from Bill Edelstein, but it talks about good principles if you want to do MRI. And one of the things that he talks about is this first point, which is that examinations should consist of 10 minutes of imaging plus 5 minutes of patient handling time. So this is a throughput of 4 scans per hour. And I would argue at Stanford, we certainly don't meet this. I think it is definitely something that we should consider and we should be able to do. And perhaps AI software can help us minimize the disruptions to our practice to get to this point. So at this point, I just want to introduce some of the ways that we're attacking this problem. This is the 2 FDA-approved products from Subtle Medical, one that focuses on PET and one that focuses on MR. And they have multiple goals. One of them is to speed up imaging, as shown here. And the basic idea here is one of using computer vision to improve the quality, much like your iPhone camera has gotten much better over the years, not because the camera is better, but because the software is better. So I think Dr. Keller will be talking about some of this in detail as we go on in the future. But the basic idea is that using the same imaging equipment and the same experience for the patients and the technologist, you can just reduce the table time, and this improves many features associated with imaging. Just an example in MRI, for example, if you're doing a spine study, a lot of these patients have back pain, they may be uncomfortable, they may start moving. If you can reduce the amount of time of the scan, you may help the patient, help your imaging facility, and improve your image quality. How does this technology work? As I mentioned, this is computer vision type application using convolutional neural networks. And the basic idea is that we learn from many different studies that have been acquired at lower quality, lower resolution, and faster time period. And we train a network when we have the output of a higher resolution image. And this is a very flexible technology. It can do more than just denoising images, as shown here, and I'll talk about that a little bit in some of the new work that we're doing at the company. The other important thing that we realized early on was that disrupting existing infrastructure is not really favored in a healthcare environment. So we took a lot of pains to make this very turnkey and allow it to work at scale. So the idea is that it works with any scanner, Instead of sending directly to PACS, you end up sending to a cloud, although it can also be on-prem if desired by sites. Processing occurs in the cloud, and then it is sent back to the PACS workstation for reading. So from the technologist viewpoint, it really hasn't changed. From the radiologist on the other end, it hasn't really changed either. So this is really important when you think about implementing solutions, that they be fit very well within existing infrastructure. So as I've kind of shared, this benefits all stakeholders here. Patients would like to have shorter scans. They would like to get their imaging scans faster rather than wait longer. And if they can tolerate them, they may not need to be called back. Facilities can increase revenue with existing equipment and improve the performance of existing scanners. And it also allows techs to focus on patients and to stay on schedule. So just like doctors, technologists also like to go home on time. And finally, for radiologists, I think it improves the workflow that they're dealing with. It reduces motion artifacts and potentially can increase referrals. Okay, one thing I want to emphasize besides those three advantages, that it's also very friendly towards the environment. This is a slide I actually got from the ACR, talking about climate change and the effects of radiology. And you can read through kind of all the details where radiology impacts climate change. But one of the things here that's mentioned is that using AI to shorten MR protocols ends up helping in terms of carbon footprint. And why is this? In particular, if you can do more imaging with the same amount of resources, that saves electricity, as well as potentially avoiding the need to purchase additional scanners. It turns out that much of the cost in terms of climate change, in terms of carbon, is building new scanners and retiring new scanners. So if you can avoid or defer the purchase of a new scanner, that has a beneficial effect on the climate. Okay, I want to shift now and talk a little bit about some of the newer things that are coming down the road so that you're aware of where this technology can go. So the first is the idea of the prediction of images from other images. So as most of you know, if you're radiologists, there's a lot of shared information between images. So a T1 weighted image looks a lot like a T2 image, looks a lot like a STIR image. So it turns out that you can use some of these existing images to actually synthesize desired new contrast. And this is just an example demonstrating the use of T1 and T2 weighted images, which are required in spine imaging routinely, to produce a synthetic FLAIR image, which actually is of higher quality than the STIR images that are typically acquired. So when you're looking at time savings, this is obviously a great application because it doesn't take any time to do this. Now, if you also have patients who are moving, for example, and an image is corrupted, there's the potential to use this to improve the quality and replace it with a synthesized image. So this work has been recognized by the National Institutes of Health. This is a grant that we're working on with the University of Washington, just showing that if you're looking at brain imaging and you have, say, 3 contrasts here, a T1 post-contrast, and a T2, maybe the FLAIR got screwed up. And for example, this FLAIR, the patient was moving, there was poor suppression in this area. And you can see that using a neural network, you can actually synthesize a FLAIR image from those existing images, which obviates some of these problems. Another area that we've been very focused on and interested in is the reduction of the use of contrast agents. So this is a project that we are working together with Bayer, but the idea is basically to inject less contrast, in this case 90% less contrast, and then use a neural network to enhance the contrast that does exist so that you have a diagnostic image that you can read. And this has a lot of benefits to the patient, obviously, but also has environmental benefits because we're learning that gadolinium may be safe for patients, but when it gets degraded after it goes through the wastewater systems and it flows into freshwater and marine environments, it seems to have disruptive effects on the wildlife there. So a lot of papers on that coming out recently. Now, another way you can use this if you don't want to change your practice at all is to just boost current contrast dose. So this is an example of a T1 weighted image before contrast. After contrast, you see a small lesion here. You can use AI to actually boost the quality of the image so that the contrast appears to be of higher dose. And this is a study and a project that we're working on with Bracco and is in the FDA pending state. Okay, the last thing I want to talk about is the idea of better orchestrating workflows at scale. And this is a product that we call Subtle Ally. But basically what it does is standardizes a lot of the things that you would like to be able to do maybe with an MD, but you don't want to waste the MD's time to actually do this. And this is having scans that are standardized in terms of naming, and I'll talk about why that's important. To do an AI-based quality check instead of having a phone call to an MD to do a quality check. To do perfect reformats every time. And finally, to provide insights into this data. So the reason that we developed this product is partially because we need it as a company. We need to know what an image is, what it looks like, and what its quality is before we start to process it. And this is true for all downstream AI companies. So some of the things that it addresses, the fact that imaging data is locked within divisional silos, it can be hard to access. Our protocols are getting more complex and variable, and this makes it really challenging to do it the first time and not have to call people back. And this can lead to radiologists and technologists getting very frustrated. And at the end of the day, can even lead to liability if your scans are not being acquired in the way that you're expecting them to be. So let's talk about naming. So you may be aware that different MRI scanners and vendors tend to name the same thing differently. And this is just an example from a large public data set where they had over 95 unique series descriptions in a set of 1,300 studies. And using this tool, we could identify what they were, and we could name them all in a consistent way. And the reason that this is important is because if you want to then downstream use these images for something, in particular for things like hanging protocols, which have always been a great desire for radiologists to have, but have never worked, this is a way to do that without having to assign someone to do a lot of very complex logic work to try to have these things work and then have them ultimately fail when a technologist, new technologist comes on and changes something. So it makes your system much more robust. So just an example here, this is a real exam, some real exam naming shown here on the left. And you can see that it's kind of ambiguous sometimes, right? Like what is a T1 3D plus minus contrast plus minus FATSAT? Well, it turns out that in this case, if you look at the DICOM header and you look at the images themselves, what you find out is this is actually a sagittal T1 without contrast, even though there's some suggestion that this is a post-contrast study. When we look at the image, we can tell that it's non-contrast, and that may be very important because if the patient needs to have contrast before they leave the room, we can alert the technologist that in fact there's no contrast on the scan. Talking about quality. So quality is really important, and motion is a real challenge for patients, especially as protocols can get longer and more complex. Rather than having technologists do a phone call to figure out if the motion is adequate or repeating studies, we can actually take an image and quantify the amount of motion. So in this case, the image on the left has been identified as a motion degraded image, on the right as a non-motion degraded image. And we have tested this with open source data sets. This is a beautiful data set of patients who were asked to either not move, to move a little, or to move a lot. And these are the scores here. The 0 is no motion, the 1 is a little motion, 2 is a lot of motion. And this is just an example of the score that we've scored these images at. And you can see that in general, the higher motion there is that the patient perceives, the higher the score that we give it. And this is just some performance data demonstrating that we can separate those kinds of scans with fairly good accuracy. Another thing that we're very excited with this technology is the idea of taking the need to reformat scans off of the technologist's plate. This is something that is becoming increasingly part of the technologist's job. For example, I know some abdominal CT studies where about 12 reformats need to be done by the CT tech. And when they're doing this, not only is there an opportunity for error and variability, but also they can't actually use that to get ready for the next patient. So the idea is that all exams should be standardized into a specific space. And this is just an example here of 3 time points longitudinally. This is the way the tech was scanning them. You can see here that the software realigns these in the same plane every time. And this helps because I don't think any technologist likes to get the call to say that the reformats need to be repeated. And I don't think any radiologist likes to make that call. So these are really very low-hanging fruit that we really should be doing in everyone. The other advantage of this, which you may not realize at first, is that we do a lot of repeat studies and we're asked to say, what has changed? And having slices perfectly aligned from a prior study is something that sometimes radiologists do manually. And I think this is a waste of time. I think that they shouldn't be doing this. They should be reading the image. So in this case, this tool can actually present the images regardless of what kind of packs you have in the same exact alignment, which makes comparison much easier. So of course, these work together. So the workflow that we envision is, for example, the use of subtle MR and allied together to take an accelerated scan, shown here on the left, to come up with a standardized name for it that everybody agrees on and is the same throughout your institution, to perform denoising to improve the quality, and then to align and reformat it in a standard plane. And I think this has value across the enterprise in many areas that helps both the patients, the technologist, the radiologist, and the people who have to make sure the shop stays open. So finally, if you do this, of course, you can get a lot of information about your scans. So as workflows become more complex and you have more sites, it's really critical to understand what's going on at each site. And this is sometimes done using HL7 type information from the EMR, but we know that that data is often not very accurate. So if you actually use this kind of system, you can know very specific things about what kind of scans are being done, how long are they taking at each site, how long does it take, for each tech to do a study, how many times was the protocol completely followed and you didn't have some sort of variance, and how, is the image quality at each site. So all these things are tremendously useful to drive improved imaging for everyone. So we're very excited about this and think that this is really a very appropriate use of AI to just help radiologists and technologists do a better job at what they're doing. So with that, I am happy to take questions. I think up next will be my colleague, Dr. Keller, but I'm happy to take some questions now if we have a little bit of time.
Hey, Greg, we had a few come in the Q&A feature. The first one was, how do you get a blocker on board who doesn't believe in the product or is skeptical of AI?
Yeah, it's interesting. AI, a lot of emotions come up when we talk about AI. So, I've seen, some responses where people are just, not confident of results, or, perhaps they're just nervous about change. I think that that's a very healthy attitude in healthcare, but sometimes it gets in the way of us, providing better care to patients. What I would say is, if you're worried about these things, certainly, asking colleagues that have used it in the past or are currently using it is always a good idea. I think, trialing it within your own institution is actually very easy to do as well. And then lastly, the peer-reviewed literature. There's, plenty of literature out there suggesting that the performance of AI algorithms for image quality enhancement is actually quite good. And, the ability to, you know, accentuate what you can do is above and beyond what you could do without it. So honestly, I really don't understand why anyone would not be using this technology at this point based on the literature that's out there and the use that's out there. But I think the the important point is to, reassure people that, change can be good in healthcare, and that this will actually, improve the quality of your images.
Awesome. One more came through. We have, what are the anticipated future challenges in scaling AI deployment in radiology, and how can they be addressed proactively?
Yeah, I mean, I think the biggest challenge in our field is that we don't have enough IT support for the level of innovation that's out there. This is certainly true at Stanford. It's true at a lot of places that I talk to. They say that, we really like this technology, but we have 6 projects. People are knee deep in work. We can't really make these changes at this time. Now, one thing I would say, the technology I'm showing you, is actually very simple to set up, and I think Dr. Keller can speak to that. But regardless of that, I think that's one of the biggest challenges that we face as a field is that, if we want to innovate, we really do need to make sure we innovate safely, that we, can integrate these technologies with existing workflows. And in my experience, the biggest challenge to that just has been the incredible amount of work that our IT staff is being asked to do currently. So I think that we either need to grow that or we need to take some things off of their plate. But if we don't do that, I think it can be very challenging to implement new systems, even if you just want to trial them. We see just the ability to trial things has been challenging at Stanford. So I'm very hopeful that this will change in some way when people realize the value in AI.
Thanks, Greg. We just had one more pop in while you were asking that, specifically with the subtle products. Do they work with pediatrics?
Yeah, so we have a close partnership with several pediatric sites. I don't know if Dr. Keller has any pediatric patients at her site, but we've been working with the folks at Toronto Sick Kids, as well as Boston Children's Hospital. And they have both implemented this technology. It is approved for all ages. I think it has a particular advantage for pediatrics in that, if kids have a tough time going through a procedure, they might be able to tolerate a shorter procedure rather than a longer procedure. And this has advantages in maybe being able to shift some cases from general anesthesia to moderate sedation, or maybe moderate sedation to no sedation. And this is really important because, doing sedation cases or doing general anesthesia cases is incredibly resource intensive, in addition to potential side effects for the young patients. So, we've had very positive, feedback from these sites, and happy to put people in touch with the colleagues at those sites if they're interested in learning more.
Thanks, Greg. I really appreciate that. That was awesome. And we'd like to welcome up Dr. Keller next.
So I will stop sharing.
Perfect.
So is it sharing properly?
Go ahead and press that slideshow one more time. And then from the beginning.
Okay,
Perfect. Thanks,
great.
Dr. Miller.
All righty. Well, that was very interesting, and I'm going to speak about the subtle product that we used in private practice and a couple other things, because it's been really excellent for us and achieved all the things that Greg mentioned. So I'm in Central Florida, and we have 6 imaging centers and about 24 radiologists. Our scanning environment is with 8 different magnets of different vintages, mostly Siemens, but we also have GE and Canon. So that's important for finding a solution that will go across all those. We have an older patient population and way too many orders for the number of appointment slots we have, and decreasing reimbursement. So with all of that, our challenges were to increase our capacity, decrease the scan times, find something we could use on all 8 of our magnets, improve the tech's workday, and improve the patient experience. With the COVID epidemic and techs being sick, we had a huge backlog. I'm in an area that has 5 to 10% growth all the time, so the number of MR requests were always increasing. So with patients having to wait many weeks for an exam, they weren't satisfied, and the referring doctors weren't satisfied. So we had to do something to improve that. So our first idea was, with looking at subtle, how could we reduce the length of each MR? And what we were able to do using that product was to decrease the scan times across all the images that we did. When we started with subtle, they were the only company that did both MSK and neuro and body imaging. And that was really important because we do a lot of body and prostate. So if you can, except for the knee there, find overall savings for each examination of at least 30%, then you're saving a lot of time. The next thing was that we wanted to maintain the image quality while we were doing that, because there's no point in having faster scans if you're losing quality and not able to make the diagnosis. But what we found was that because of the subtle product that we used, some of the images are actually better. If you look at the after subtle, we saved time, and you can actually see the internal structure of the prostate better there, which is fantastic. Here's a cervical spine. There's no difference with the shorter subtle image at all. Same with the lumbar spine, very common examination. It's very easy to see the disc protrusion, all the anatomy that you need. Here's a knee. You can easily see the menisci, the cartilage, the bone marrow, the collateral ligaments. So no problems there whatsoever. And with an axial lumbar spine, just another example, there's no difference whatsoever, and there's tremendous time savings. You're saving half the time there. So that's great. The image quality is maintained and it's a faster scan, but does that really equate to more appointments for our MRs? Well, it turns out that for the 3T magnet, we were able to get about 6 more patients a day. And for the other magnets, the 1.5s, about 5 more patients a day. So, you know, on average, we got about 40 more patients a day for our system. And that's really the equivalent of buying another scanner without buying another scanner. The other thing is that because of the faster scan times, when it comes to the 3T, you have to be concerned about the specific absorption rate, which is the energy deposited in the patient. So if it's a large patient, you may have to alter your scan parameters in order to meet the requirement that you're not putting too much energy into the patient with the SAR FDA rules. So when the scans are already protocoled to be faster with subtle, then you don't even have to go through that. So that's another time savings so that you get to the scanning right away, and it's easier for the technologist as well. What about the patient experience? That was another goal of ours because, as I mentioned earlier on, we have an older patient population. About 70 to 75% of the patients are 65 and older, so some of them don't move as well, they don't hear as well, they're in pain, and they need added help and care. So we were able to return a lot of time to patient care and improve the patient experience. If a patient is on the table for a shorter length of time, it's easier for that patient to hold still during the scan. And especially if you're in pain or you have arthritis, that's really terrific. It also means with less motion, there are fewer times that the technologist needs to repeat a scan. And that's better for the technologist as well as for the patient, because then the tech doesn't get behind in the schedule. We really never wanted to make this about pushing patients through like a cattle call, but really had a goal to improve patient care, improve the timeliness of examinations, and that gives you better satisfaction for the referring doctors and for the patients, because they get an answer of what's the matter with them and get onto their treatment protocol faster. And we did all of this while keeping the same diagnostic quality of the exams. So that was really a win for everybody all around. And how about how well can you actually implement this? Well, from the time that we signed the contract and got IT involved to make the different hookups and then put it across all of our imaging centers with 8 different magnets, that was about 3 months total, which I think is very, very fast. We were able to make this scalable to all the different vendors and our different machines. And we actually found that we were saving money from not buying another machine, but also we increased our revenue at the same time, about $2.1 million, because we had more patients that we were doing, so that's added reimbursement from them, and we decreased our tech overtime. So that's just fantastic. Well, launching the software across the different models of vendors and scanners and software and different techs, each site has a little bit different workflow. You know, that was a bit of a challenge, but we were able to do that fine because the Subtle system is just so easy to implement. And their clinical specialist was just excellent in working with us. Initially, we used 2 MR techs on each scanner because of the increased patient throughput. But once everyone became more comfortable and accustomed to things, then we could go back to having 1 tech with 1 or 2 aides. So really, it was the collaboration between the Subtle customer success team and our MR techs and supervisors that made the deployment and adoption across the enterprise very easy and very successful. So I don't think we would want to do without it now, because it's just so terrific in terms of increasing speed and making everyone's life easier. One thing that was mentioned earlier today was about the synth, which is combining different images to make a new one, and that takes no time at all. So you have 100% time savings. We used this as a pilot and did it just with some cervical, thoracic, and lumbar spine images on one of our 1.5 Siemens scanners. And this was additional time savings on top of what we were already getting. The image quality was better. And with the cervical spine, we were able to see lesions in the cord better, which is always nice. So here are some examples of the increased quality because of the high signal to noise. You can see in the green box is the synth. Here's another one where you can see much better compared to the original on the far right. The quality is much improved. And here's one where there's just much less artifact. So this is a real improvement. You don't have to repeat the scan. And if you were doing this with the synth to start with, it would just be the T1 and T2 sagittals and the axials. You wouldn't have to do the stir image at all. And there wouldn't be any question about, do I have to repeat anything? You just go right along with it. So here's a cervical spine, and you can see at the arrow, there's a faint area of white dot, which was a lesion in the cord, but on the synth stir, you can see that real well, and you can even see it on the axial. So I think that's a nice way to confirm for the radiologist that this is a real finding. Let's change gears and go to mammography. mammography is an area where you have, just like MR, way too many patients, not enough radiologists, not enough technologists, and there are different things that you have to do in order to comply with the Mammography Quality Standards Act in order to manage your practice. The only way to have mammography be cost effective is that you have to have high volume and an efficient practice. So what can AI do for you with mammography? Well, the three main things that it can do: you can evaluate breast density, and that plus some tricky AI can evaluate the risk of cancer, which is a future development in breast AI. Why do you want to have automated breast density analysis rather than just the radiologist using a subjective assessment? Well, you get better uniformity and consistency of the analysis, and that's important because the MQSA is requiring that everyone report the density on the lay letter to the patient later this year, but also breast density is what drives a lot of supplemental screening in women with dense breasts. Another thing that you can use the AI for is, as far as the MQSA equip analytics, where you have to do a 12-point evaluation of the image, and it's as a result of needing to do that for every mammogram and for every tech and every machine and every location. You can imagine that the combinations and permutations of all that, if you do any volume of mammography, is huge. So by having an automated way to do this accurately, you save a huge amount of time for the radiologist lead interpreting physician and for the lead tech. I think it would be impossible to do without this automation. And then the last thing, but one of the most important, is the image analysis of the mammogram to help determine what's normal and what is a mammogram that is suspicious for cancer. So in case you don't know, the breast density that is analyzed has to do with these four densities, and from the left to the right, they end up being labeled A, B, C, and D. Remember that the mammogram is a black and white image, and this first woman here in her breast that's compressed top to bottom. So here's the skin, this is the chest wall, that's the nipple, this is the armpit side, and that's the breastbone side. She has no dense tissue. The dense tissue is fibrous and glandular tissue. It shows up white on the mammogram. The only reason that's an issue is because cancer shows up white as well. So seeing white on white to find the cancer can be difficult. This person has some dense tissue and is determined to be scattered fibroglandular tissue, or the letter B like boy. This person has more. It's filling the majority of the breast. It's termed heterogeneously dense and has small nodules, so that makes it difficult to see an abnormality. And this last person, extremely dense, is the letter D like dog, and that's about all that's there is the dense tissue. So you can imagine that that makes it difficult to see a white abnormality superimposed in there. So this is an example of the Volpara company's breast density report, but there are several other companies that make density reports as well. Densitas, Hologic, iCAD, many others. So what it does is to evaluate the volumetric breast density, and it gives you that for each breast, and at the same time it tells you what the dose is and what the compression was. That's important because these are things you have to report to the MQSA. Now, moving on to the idea of analyzing a breast for the presence of any abnormality. If you're reading a mammogram of a woman like this with an extremely dense breast tissue, it takes a long time to look at this, scroll through all the slices, look at the old ones, and try to determine whether there's anything significant or not. You know, is this important here? Is that important there? What about these little places? Are those normal or not? Well, if instead of that time-consuming process, what if the first time you open up this case, you could see a report that let you know there are two places to really be concerned about in this breast, and it's on the right-hand side, and you know that there's an elevated risk of breast cancer. reading a mammogram with dense tissue is a huge challenge, but if you have some assistance like this, then it can be quite helpful. So what is the usefulness in dense breast women? Women with dense breasts represent about 70% of those that get a breast cancer. And we know that the mammogram is less sensitive to abnormalities when there is dense tissue. In fact, the sensitivity decreases to be about 50%. But if you use one of these methods, like the Transpara, the one that I use, then you can increase your sensitivity. So if you see in the women that have the C and the D density, here's what the radiologist found, and it's the higher pink bar is the greater sensitivity of what the AI was able to find. So there was a sensitivity that increased to 80%. So that's almost a 30% increase in sensitivity, which means that you're better able to find cancers in women with dense breasts and then have a better outcome as a result. So all of the vendors do something similar. They have a report that comes up. There's a bounding box that either shows a mass or a calcification. It gives you a score from 1 to 100, or some give a letter score of how risky they think it is. It tells you whether it's a mass or calcification and tells you exactly what slice to look at. Most of the companies only have 2 markings per side, and so that's a total of 4 for the entire study. They give you a score for each mark, and then an overall score, as in this report in the lower right, for the study, which combines both views. And that helps you out because you know whether it's normal or has an intermediate risk or is high risk. And once the radiologist becomes accustomed to the reporting, it really increases confidence and speeds things up. This is an example of an intermediate score. So you see the scores in the 50s instead of the 80s. And this is a patient with a low score. You notice it's low. There are no marks whatsoever on it. So you're not having to look and see, is this normal, not normal? No. If it's normal, there are no marks whatsoever. And that's important because if there's a high negative predictive value, that means it's very specific for being normal. The Transpara has a 99.7% negative predictive value. So that's better than a radiologist at reading the mammogram. Well, it's helpful because there's so much volume. And if you can have better confidence and better speed with reading, that's quite helpful. So what happens when you use this? If you're using the Transpara, you have about a 26% less reading time. And that has to do with the fact that so many patients are actually normal in a screening population. Maybe 60 to 70% of the women in the screening population are actually going to be normal. So if you have a way to rapidly recognize them and not get caught up with, is that a lymph node or a cyst, or it's nothing at all? Is that just some asymmetric tissue, or is it something I have to work up? That is a huge time savings. I've been using this since last May, so it's almost a year, and all of us who have adopted it are really very happy with it. Another thing is that the Transpara is the only one that's done a randomized controlled prospective trial using the AI rather than just a reader study. And that's important because it looks at how does the AI work in the real world. There was a question after the first half of this about how do you convince blockers to adopt AI. Well, having a randomized controlled prospective trial is a great way to do that, because then it's not just in some fictitious setting, it's a real world use of the product, and you get to see what happens. Well, this slide is prepared from preliminary results that came out last year in Lancet Oncology in 2023, but actually at the European Congress of Radiology earlier this month, the final results came out, and that showed that in the AI arm, the cancer detection rate was 6.4 out of 1,000. So it actually went up in the final results from what's shown here. And in the double reader side, it went down to 5 per 1,000. So that's an increased cancer detection rate, which is excellent. But also there was a time savings of 26% for single readers, 44% for double readers. But also important is to think about what is the recall rate, because the recall rate is a big potential harm of mammography. The woman has to come back, leave work, take time, have more radiation for additional imaging potentially. It costs more money. It takes more time for the radiologist. Here in Europe, the recall rate tends to be somewhere around 4 to 6%. So their recall rate went down to 22%. In the United States, the recall rate is allowed to be as much as 10%, but in some places it's as high as 15%. So even if you decreased it by half down to 6%, the same as the European, and everyone was still finding more cancers and having shorter reading time, you can see how that would be tremendously beneficial. What about the analytics that I measured? These are some of the ridiculous numerous things that you have to do in order to manage the analytics for the MQSA. You know, the MQSA is the Mammography Quality Standards Act, and every mammo site has to be accredited in order to be reimbursed. It started in 1992 and has gone through a few iterations. They added the EQUIP, which stands for Enhancing Quality Using the Inspection Program, in 2017. And what that requires is that you look at each and every mammogram performed by machine, by site, by technologist, and evaluate for all these different aspects of the image in the MLO and the CC. And the reason they decided to do that is that the number one reason that sites were failing their accreditation or their reaccreditation had to do with poor positioning. So this is showing you again all the different spots that you have to look for. Now, it's an example of the slide from Volpara, but Densitas is the other company that does that. So you have to make sure that the nipple's in profile, the nipple's in the midline, there's IMF that you see, the inferior mammary fold, there's the right amount of distance between the nipple and the chest wall. You have to have multiple features that you rely on in the pectoralis muscle. So it ends up being 11 different features. When you add in the compression and the radiation amount, then that makes 13 features. So the mammogram gets designated as being perfect, good, moderate, or inadequate, that it needs to have more work done. Well, that's pretty hard to go through a huge number. Our system performs 53,000 mammograms a year. Can you imagine trying to evaluate each and every one of those in each tech? But if you have an automated system to do that, that then scores the whole system from the mammograms and by technologist, machine, and site, and tells you a quality score overall and the positioning and also the compression, then it gives you a result. So when we first started this was in December of 2021, and it showed us that we were doing fine in our quality and positioning, but we could use some improvement in the compression. And what happens when you do all of this, all these metrics, and you do it by technologist, then you have to give a report to the technologist, and it shows the technologist where she has need for improvement. There are little short videos with education that are in the system, because each tech can log in and get that information and get a CEU for that. So this is another company that does it, Densitas, which is a similar thing, but one of the things that they do differently is in the reporting for the technologist. The lead tech has to tell each technologist how she's doing, and the more frequently that you are able to give feedback, the better that's going to be. So what this company did was to use AI through a ChatGPT kind of system to look at all of that data for each tech and summarize it in a way that is very meaningful, rather than have to have the lead interpreting tech go through all this quality data and try to figure out and make an explanation. This one does it by generating a nice report that the tech can then check and make sure that she agrees with it and give to the technologist. So in this example, the technologist is Tracy, and she's ranked number 1 out of 11 in her group, with 53% of her mammograms being perfect or good with their positioning. Then they look at her trends over time, and it says that there's some decreasing trend of positioning errors are trending down, which is good. And overall, her errors are 8% lower. The other advantage of this compared to when you just do it with the chief technologist is that this is an independent way that's unbiased. Tracy is not getting a better review because she's best friends with the chief technologist on the side. It's clear and concise, and it really has enhanced the feedback for the technologists. Here's another one that would be kind of hard to figure out. Looks like she's doing great, but what does this graph mean? Well, here is the example of Charlotte. She's 5th out of 5 technologists, but it turns out that her performance really isn't different from the other technologists in her group. And that's something that would be hard to know without the lead tech doing a big comparison. This person has 48% of her exams are perfect or good. Her positioning fluctuation is not trending really anywhere at all, and her fluctuation in positioning is actually 0.5% less than the organizational average. So that's a very useful way to get that information out to the technologist. And if you have a tech that's doing well, then the lead interpreting tech can just email this out and say, if you have any questions, let me know, which allows the lead tech to spend more time with the ones that need help. So again, that's time savings for your lead tech. So what does this make for a summary? You need to think of AI as being an assistant, the way we saw what Subtle can do. It can help with workflow and productivity, decrease costs, and make things easier. We don't have enough radiologists. We don't have enough technologists. Reimbursement's going down, and the volume is burdensome. So we have to find ways to work smarter and not harder, and I think AI is perfect for that. Another thing is that you need to choose a vendor, a partner that will be helpful to you with implementation and can help you understand what your return on investment will be, help you with implementation, and have robust future products. So for Subtle, they increased our capacity while we decreased our cost. We maintained excellent image quality. The patient experience improved because they had decreased wait times, fewer rescans, shorter table time, gave the techs more time to focus on the patient. So that was excellent. With the Transpara, we have increased cancer detection rate. We're saving time and increasing the confidence of the radiologists so they have less stress and less burnout. And with products like the Volpara and the Densitas, the lead technologist has more time. It's easier for her. There's improved communication of the data to the mammotechs, and they have improved performance. And it makes compliance with the really burdensome and onerous requirements of the MQSA better. So that's all I have to say.
Thank you so much, Dr. Keller and Dr. Saharchuk. We really appreciate having you both on today and sharing how we can really scale AI and see it in our practice. And attendees, thank you all for attending and for a great final session in our series. Before you go, take a moment at the end to fill out our survey. You'll receive a link when the webinar closes. Your feedback is crucial for shaping future programs. Again, thank you all for joining. Have a great day.